welcome to all the panelists. So I think, can I have the first slide? Right. So I think there are newer changes which are happening now, and we have evolved in the last decade or so. And this is one, summary slide which I've taken from one of the presentations. First line, second line, third line, resectability assessment. So which is very, very, very important for patients with metastatic colorectal cancer when the disease is confined to liver or to, one or two areas where the resection is possibility, because that does help you in figuring out what is the selection for the biologic and even for the chemotherapy partner. And FOLFOX or Zelox, FOLFIRI, and now I think there's a lot of discussion on 3 drugs, which is the combination of FOLFOXFIRI in several situations. I think cetuximab and panitumumab was covered, and it still remains an important thing. So, and of course, bevacizumab. So can I have the next slide and begin the panel after having this discussion? So can I ask Dr. Ghanshyam? Sir. Good afternoon, Dr. Ghanshyam.
Sir, good afternoon.
Right. So any patient, well, let's keep aside the resectability portion. Metastatic CRC, you find maybe multiple liver mets or peritoneal mets, and you have the tissue from the sigmoid colon showing adenocarcinoma. So what tests are you going to perform in this individual?
So in my practice, so at least the 5 common tests. So KRAS, NRAS, BRAF, HER2 and MSI. So at least this much.
So everybody agrees. Sandeep, is that the practice in the Max Hospital?
Yes, sir. Same practice. The 5 molecular markers that Dr. Vishwas right now said: KRAS, NRAS, BRAF, HER2, and MSI.
Dr. Darshana?
I do agree. Same 5.
Same 5. Dr. Chandrakant, you have anything else to add?
Sir, HER2 we are not using routinely right now, but it would be great. We should implement that in practice.
Okay, so HER2 people are not using. Why, Dr. Chandrakant, why is that? It's readily available, right?
So it's available, sir. I agree we should use more often now. KRAS, NRAS was the compulsory. Now BRAF somehow we have picked up. And HER2, yes, we are picking up, sir.
And what about MSI?
MSI in an advanced stage, not yet in all patients, but in a young patient, when it is there, we are doing. I agree we should do MSI in all patients also.
I thought Dr. Vikas, yeah, Dr. Bowman, yeah, please.
Yeah, I think so. MSI-MR is now supposed to be the backbone. If MSI is high in front line also, you can use Pembro. And that is what the up-to-date also says, that the classification starts with MSI-MR in a metastatic disease.
So Dr. Vikas is also on the panel. Viraj, is Vikas there?
Yeah, but he's logged out somehow. He's joining back.
Okay, so now coming Viraj to you, I think it's an important question. So they want to do 5 tests. So you're still leaving behind NTRK, RET. So I think NGS is available. So are you a proponent of NGS in metastatic colorectal cancer?
So to answer your question, for second line, yes. First line, I do NGS. I have started doing NGS, but that's not for fusions. That's not for any targeting treatments. But we know that we often forget KRAS amplifications. That's something which you don't pick up on your RT-PCR, KRAS mutations. So even those are predictive markers for poor prognosis, poor response to anti-EGFR. And I have had a KRAS amplified tumor very recently. and which you would miss if you do a standard RT-PCR. So yes, cases are beginning up if the tests are, as I told you last time, that 25-30,000 panel, it's not that expensive. We can consider using upfront for majority of cases.
So, Dr. Bowman, you're sitting in Mumbai, which is the financial capital of the country, and people want the best. So, are you? Is it prime time to switch to NGS upfront in all patients for metastatic CRC?
Yeah, I think so. It is to have the information is always useful, but what you would practice may not be so much, So getting the information, yes, like we know BRAF is positive, so our EGF, this different type of treatment we'll be using. If HER2 is positive, we have the information that our EGFR drugs will not be useful so much. So getting the information is useful, but what you would practice will be a discussion with the patient.
Right. So Sandeep, in Max again, corporate sector. So are you willing to switch to NGS?
Actually, the cost of the treatment is already enough for me not to advise NGS in the first line. If there is a cost-effective NGS available,
I don't know.
I would.
I don't know. Once you have a biologic incorporated in the treatment, so the cost of NGS is hardly anything. I mean, it's like a one-time expense.
I would try to use the money that is reserved for the NGS for the targeted therapy.
The money reserved will be half the cost of 1 second.
Exactly. Ghanshyam nailed it.
So it all depends. It all depends upon which type of NGS, whether it is an Indian clone of the standard NGS or the standard NGS that you are sending.
No, I mean, Dr. Chandrakant, are you okay doing the NGS from Indian company?
I'm not able to hear you, sir. No, not able to hear you.
Your audio is not available, sir.
No, sir. Not audible, sir.
You are not audible, sir.
I think the connectivity is lost from Dr. Aggarwal's side. He will need to re-log in.
He must be rejoining actually. No, sir. No.
Hear me now?
We can see you, but your volume is very less.
I don't know, rejoin.
Yeah, better, sir. Better. No.
Ghanshyam, these local tests from various labs like are you okay to?
Ravindra, you think you can help him?
Sorry,
the voice is very low.
So you can join back, no, sir. So
I did that. I did.
Sir. Yes, sir. No. Yeah.
I did that.
Yeah. So he can hear you now.
I see some hesitancy on the part of medical oncologists to switch to NGS and sticking on to those 5 tests by PCR and IHC and so on. So isn't it high time that we start doing NGS? Ghanshyam?
Yes, sir. So we are already shifted in lung cancer. So why not in colon cancer? So we are talking about first line, second line, third line and beyond. So yeah, it's prime time, sir. Definitely.
Dr. Chandrakant, you agree? Dr. Chandrakant, can you hear me?
Sir, I incompletely heard, but I said there is a hesitancy for NGS in practice because all my patients won't be able to afford the pembrolizumab or cetuximab or panitumumab. So even bevacizumab is a challenge in our set population. So I would not reflexly do NGS in a patient who is not affording. In a patient who is affording, of course, I consider the NGS. It's all about affordability in practice.
So that point is very well taken. But in a patient whom we are contemplating using a biologic drug, so I think NGS should be certainly discussed with that individual, because yeah.
So besides these 5 markers, what will help you in the NGS so as to plan your treatment more effectively as far as targeted therapy is concerned?
So Viraj, you want to take this NGS and the importance of NGS in CRC?
Yeah. So like Sandeep sir is asking on the first line, right? When the newly diagnosed patient has come to your office,
Yes.
what additional information would NGS give over these 5 markers? So as I told you that there is one thing called KRAS amplification. There are other KRAS mutations which let me finish that. So there are KRAS mutations which is about 1 to 1.5%, which you would miss on RT-PCR. So that's about RAS. Also, let's say your patient has an MSI high and you want to consider Pembro. We know now that if this patient has low TMB or intermediate TMB, they are the ones who are going to have the rapid progression. And you might, if you had that information with NGS, you would consider sticking to standard chemo rather than giving them upfront Pembro. So definitely there is a science behind doing NGS. And as Dr. Chandrakant said, if cost factor is removed, I would do NGS for all patients.
So Shyam sir, I have another input. So doing an NGS, suppose we have a left-sided MCRC and we are planning for an anti-GFR and you have picked up a BRAF or MSI or a HER2 new. So you know that even it is a left-sided tumor, so your anti-GFR is not going to work. And second, so there are drugs on a compassionate on a NTRK today that's available. And if you have picked up, though it is 1%, so at least you can put into a clinical trial, you can refer your patients, or you can always benefit the patient with the compassionate drugs that's available.
Right. Dr. Darshana, you want to make any comment on NGS versus the 5 tests?
So upfront, when the patient would come on an endoscopic diagnosis, the tissue sample is often small. So if the patient is affording at that particular moment and metastatic, then I would definitely offer NGS.
So I do see, the pendulum shifting towards NGS. And to reiterate that point, I was conducting a panel in which there was a European, person who did say that they have switched on to NGS on the tissue and not liquid at the moment for determining these gene mutation status so as to decide what is to be done in a given individual. So now, coming to the individual gene mutation analysis and the selection of, chemotherapy backbone and the drugs. So I put in FOLFOXFIRI as the backbone. So is it okay to say today that we have moved from, a doublet to a triplet in our practice for most of the situations? What do you think, Dr. Sandeep?
No, sir, I'm still not using the 3-drug combination.
Okay.
In majority of my patients, it's a sequencing.
Let's exclude the elderly, unfit individuals, patients who are supposedly fit and who are, candidates for downstaging or otherwise they have, metastatic disease. So would FOLFOXFIRI be the default chemotherapy, or you say no, it is either FOLFOX or FOLFIRI?
So if it is with the intent of a conversion therapy to make the patient resectable, then definitely FOLFOXFIRI is a big yes. But if it is only because of the bulk of the disease and patient is never resectable, then I will not use the 3-drug, I will use the sequencing.
So I think what I'm getting is that for a patient where you want to downstage, there he is happy with FOLFOXFIRI, but otherwise a doublet is for palliative setting or for metastatic disease, a doublet. Ghanshyam, you agree with this statement?
Yeah, so young fit for a conversion, so yes.
Okay, you agree with Sandeep. Dr. Darshana?
So if the disease is metastatic, but the burden is still small, I would still I have seen excellent results even Capox and FOLFOX. If the burden is really high and I want to really consider resectability, then I would use the FOLFOX.
So Dr. Sandeep and Ghanshyam, you will agree for BRAF mutation, not using a doublet, using FOLFOXIRI?
Absolutely, because but BRAF patients, so in clinical practice and literature, so they are usually elderly and they have a poor performance status. So though that is recommended, but many patients doesn't fit into that. So though it is a rash, but you'll not find a suitable patients. Otherwise, definitely a big yes for a rash mutated, a BRAF mutated.
Right. So Dr. Chandrakant, doublet versus triplet, your thoughts and your choice before I go to Dr. Bowman. Yeah.
Yes, sir. So I agree with whatever made, sir. We have this TRIBE2 data, FOLFOXIRI with BAVE, then maintenance IFU BAVE, and then again re-challenge with FOLFOXIRI BAVE. So, and there is overall survival benefit. So I believe that EGFR is not the way to go. In those set of patients, like even in a KRAS mutant, a BRAF mutant, whenever there is opportunity, I would try and give a FOLFOXIRI BAVE because there is a OS benefit in these patients. Otherwise, they help with doublet chemotherapy. Of course, fitness is very important.
Right. So we're talking of fit patients. Dr. Bowman, triplet versus doublet in fit patients, palliative setting.
No, not in a palliative setup. We are not very comfortable. I would not be very comfortable in using that. But rapid cytoreduction, the FIRE3 study also showed that forget about left side, even right side, if there is a rapid cytoreduction is your aim in a fit patient, yes. And I showed you Macbeth study. If you have seen what I was presenting, then the Macbeth, that was a phase 2 study. It also showed that FOLFOXIRI plus cetuximab, if you have in your mind a rapid cytoreduction, that is the way to go ahead.
So, Dr. Viraj, your final thoughts on triplet versus doublet, because I think I have a slide showing subsequently there is some survival advantage even in palliative setting when you use FOLFOXIRI as compared to a doublet. Viraj.
Yes, sir. So for a fit patient, I do FOLFOXIRI for all patients, whether my goal is conversion or just disease palliation. And for the sole purpose, we have TRIBE2, where they categorically ask the same question when you add drug A plus B versus A followed by B. So sequencing lost on overall survival grounds. Although I would not agree to the exact strategy that FOLFOXIRI, break, and then FOLFOXIRI, what I do is FOLFOXIRI, break, and then FOLFIRI, because bringing the oxaliplatin back is a challenge. But yes, 4 months of FOLFOXIRI maintenance, then at progression, you bring back FOLFIRI. That is how I do. So TRIBE2 has, I don't think so there is any argument. And in the subset analysis of TRIBE2, they very clearly showed whether your goal was conversion, whether your goal was palliation, whether it was right side, whether it was left side, whether it was BRAF, whether it was not BRAF, irrespective, there was a benefit of triplet compared to doublet. So I use triplet for all fit patients.
Right. So this is what this slide also, tends to convey, that all fit patients, whether for palliation purposes or for cytoreduction purposes or for downstaging purposes, perhaps need to be offered a FOLFOXIRI, which is a change from our previous thinking in the last several years. And I don't find favor in at least 5 of my colleagues here who are still, and I'm perhaps one of them, not moved on to FOLFOXIRI in all cases. But I think the trends which are emerging and the data which is emerging is favoring the use of triplet rather than a doublet. Sandeep, any comments? Again, I'm trying to, play the, the devil's advocate or whatever to push, to switch people from doublet to triplet, like what Viraj is saying.
So the only concern is the quality of life issues as well as the dose reduction that is being needed in the triplet. That forbids me from its use commonly in the metastatic setting, even though the TRIBE data shows there was a survival advantage, but not at the quality of life. And per se, our patient population, tolerating a triplet in the full dose is a real challenge. So I still stick to, and you also said that you probably are not using in all your 100% patient. The same here. A patient who is fit, I require a conversion, and I think that patient can tolerate, definitely a triplet would be a go-go, but otherwise majority it is a sequencing rather than triplet.
Okay, so I think there is still people are wanting more data to support the use of triplet, at least in the palliative setting, maybe a better survival advantage before, physicians or medical oncologists routinely switch to a triplet and leave the doublet. Viraj, yeah.
What happens when you treat a pancreatic tumor? At that time, quality of life does not come into picture, or what? Because there I see everybody using a triplet, and they are even more sicker than colorectal. And we all do dose adjustments. I don't think so. We'll have a better survival analysis than a TRIBE2 for a triplet. So waiting for new data is not going to happen.
So Viraj, basically in pancreas, you already know it's a deadly disease. So probably beyond first line, you might not get the opportunity to use. Thankfully, in the colorectal, you never had such an aggressive disease that if you are not able to use a triplet, you will never be able to use a doublet or any other combination. And that's why pancreatic cancer patients, despite being O6, despite being more advanced, you take a chance for FOLFIRINOX because that's the best bet for them.
So my point is the quality of life is the issue for majority of the physicians. And I think it is not that bad. We all are more experienced from the pancreatic world, that if given in a nice way, we are all experienced to how to deal with triplet.
Yeah, I think we've learned from pancreas experience. But you know what Sandeep is saying is, wahan pe to it is like marta kya na karta. So
very right, sir. Very right.
So you have very little else to offer. Whereas here, for a couple of months or 2 or 3 months advantage, you are challenging the patient's quality of life and other issues. So I think that is what I see from Ghanshyam, from Dr. Bowman, from Darshana ji, and from Dr. Chandrakant. That is the mindset which we are still yet to, I believe. Dr. Bowman, your thoughts of wisdom in this?
Yeah, I'll tell you, as Dr. Viraj said, even in a pancreas patient, we don't give everybody enough FOLFIRINOX. If the patient has a poor performance status, we select out our patients always, whatever we do. So selecting the patient is the most important, and what your experience with that particular regimen is. So after giving maybe more of FOLFIRINOX, in colorectal, and the confidence comes in us, we may start using in more sicker patients also, I agree. But at present, when your mindset is that FOLFIRINOX is a regimen for a fit patient, so selecting out is the most important thing. And that comes only, I think so, with a lot of your experience and your previous experiences with the treatment.
No, sir, I agree. We were talking about fit only.
Fit patients.
So I'm not going to give this to a 75-year-old.
Yeah, that's right. So pancreas patient also we select out. We don't give for all patients, na pancreas.
On a 40-year-old PS0, I don't see an argument for using a doublet. That was
yeah. In a metastatic disease.
Even if it means that there is no conversion.
Yes, I think you made your point. I think we understand, and I think the data is supporting FOLFOXFIRI or FOLFIRI, the triplet in the overall survival, and that is one reason, at least but I heard you in one of the previous panel discussion, Viraj, that for a right-sided RAS wild type patient with, say, liver metastasis for conversion, you will not use a triplet with Erbitux. Is that what you were saying?
Yes, sir.
So why is that?
Why?
So I know Bowman sir showed a MACBETH study. We have
and I showed Fire 3. Fire 3 also says
we
that.
have a WOLFI study, and all the trials showed improvement in response rates. I agree. So when you're shooting for conversion, you do it. But it's still that I don't have an answer, and I'm sure nobody has answer.
Okay, so you don't have an answer.
Viraj, Fire 3 study also says that.
So I think that brings me to the question on the conversion in a RAS wild type right side. Will you use anti-EGFR? Ghansham?
No, sir. At this moment, no. Not in the first line.
No, not for conversion. Dr. Darshana, please.
Sir, no, not at all. Not for the conversion.
Not for conversion even. So you will use a BEV along with a doublet.
A doublet or plus or minus BEV actually.
Yeah, doublet plus. Okay, Sandeep.
So I would say that if it is with the intent of the conversion, considering the response rate that are achieved with the anti-EGFR, even the right side, I will use an anti-EGFR in combination with chemotherapy backbone. The reason being the data of the left-sided tumor is a retrospective data. We don't have a prospective study which has told us the data of right versus left tumors. So when the response rate is my target and I need a conversion, I will use anti-EGFR with the chemotherapy backbone in right-side tumors as well.
Okay. So Dr. Chandrakant?
Yes, sir. Huh, sir.
Right-sided wild-type tumor for conversion, for cytoreduction. Would you use EGFR or would you use
FOLFOXFIRI plus EGFR, sir, if feasible. And sir, I was having a comment on using TRIBE2 data. TRIBE2 did not use anti-EGFR. So if you have a left-sided metastatic colorectal cancer, fit patient, should I use FOLFOXFIRI plus BEV or should I use FOLFOXFIRI plus EGFR? So this one was there in mind. So TRIBE2 that doesn't classify the antibody based on the RAS mutation status. So right side, I agree, sir, EGFR.
Dr. Bowman?
Yeah, means I'll be very
It's a
comfortable.
divided house.
Hello?
So it is a divided house here.
Yeah. So what I was thinking is that if there are any contraindications for bevacizumab, my idea becomes very clear. Use EGFR, and FIRE3 study also has shown very similar results, that rapid cytoreduction is the way, and those who had shown a rapid cytoreduction have an improvement in overall survival. So it will not be a bad idea to use cetuximab or panitumab with EGFR based therapy along with FOLFOXIRI for rapid
Yes,
cytoreduction.
I mean, what I'm getting is that using the EGFR drug even on the right side for conversion is acceptable to, I would say, 50% of the medical oncologists. Viraj?
Yes, I see that, sir.
Yeah, right. So I think that is what I was wanting to drive at. So can we go to the next slide? Let us come to some of the newer things which I could locate or maybe worth discussing. So this is the Pembro data, of CRC first line, and what they've shown here is that the KRAS mutant is not benefiting. Although the numbers are small, this is a subset analysis. So anybody has a comment on this, and can I have the next slide? Next. Yeah, I think there was another slide there. Can I think this was discussed in the morning, the MSI, the numbers. So do you see that 20% or so in stage 2 MSI high? Sandeep, in your experience, or is it lower or what?
Lower, sir. I would say only 5 to 10% of patients in stage 2 are MSI high. Majority are 90% are MSI low.
And what is the methodology do you use for testing?
The first screening is the IHC, but patients who have a strong family history, we go for PCR additionally in those patients.
So, or do you do that for if somebody is to be given a immune checkpoint inhibitor? So do you confirm that by PCR after?
No, sir. If IHC has already shown it is a MSI high, then don't confirm it. But if it is an elderly patient who is not fit for an intensive therapy or chemotherapy and IHC is negative or MSI stable, then we definitely resort to PCR in such patients.
Okay, Dr. Darshana, my question is that if you have MSI high on IHC, before putting the patient on immune checkpoint, will you go for a confirmatory test like PCR or NGS, or would you just accept IHC?
Really, I do not worry that test additionally. I accept the IHC and go.
Dr. Chandrakant?
Sir, would confirm by PCR.
Right. So Dr. Viraj, do you think it's you should accept the IHC?
Yes, sir.
You can,
The concordance is more than 92 to 93%. So even even the label does not ask us to confirm with PCR or NGS. IHC is good enough, and that was also used in the clinical trials.
and do you find it more on the right side, as this cartoon says?
Yeah. So in the early clonal panel, again the same thing was reflecting that in India we're not seeing MSI high, but somehow where I am there, about 80 to 100 colorectal surgeries happen every year, and I see about 15 to 20 MSI every year. So I think so these numbers are reflecting my practice.
Yeah, even at Gangaram, I think the incidence is not that low. I mean, it's not uncommon, but you do see 10 to 15%, especially in early stages like stage 2.
Yeah, T3N0. Invariably, T3N0, will have a DMMR, and I would not have to give chemo.
Correct. Right. So can we move on to the next slide? So I wanted to make a point on this one. So the selection for MSI high patients, although I understand the incidence is low, is between the Nivo Ipi, because both these drugs are available, versus pembrolizumab. Can I have the next slide? And you see the response is much higher. And if you see the KRAS mutant population here, so as per this study, the resistance which is seen to pembrolizumab is overcome by using Nivo-Ipi, and at the moment the cost isn't different. So why should I offer pembro? So I want comments from Dr. Bowman. What do you think?
Yeah, what you are showing is, of course, but somehow or the other, it's like Nivo plus Ipi, you're using it, you should be well prepared for immunological toxicities, and you should be well versed with that regimen. Whereas with pembro single agent and pembro with chemotherapy, we have learned from our lung cancer everywhere, that's so well tolerated single agent pembro that we don't have to really worry about the toxicity. Here, the toxicity will be a little bit of an inhibition for us right now. Jump.
Any experience for anybody using, immune checkpoint inhibitors, including pembro for metastatic CRC, and their comments on this issue of Nivo-Ipi versus pembro?
So I have a comment, sir. With pembro, we'll see that one third of these patients will be hyper progressors. So, that is one thing, and we see that the forest plot is not favoring the KRAS mutant. But this combination, so as we have discussed yesterday, also Viraj was there. So this is working in lung, that is working in RCC, SCC, the LEAP trial. So this combination probably is making waves into all cancers now. So that is one take, and you have justified that even the mutant population is also responding.
Yeah, and Sandeep, any thoughts or any comments?
So right now, 2 patients ongoing with the MSI high status immunotherapy. Incidentally, both of them progressed on first-line FOLFOX, second-line FOLFIRI. They were not fit enough for a FOLFOXFIRI. As soon as the immuno was started, since Nivo was giving a support program, Nivo was started. Within 2 months' time, there is a dramatic response. So I think immunotherapy, the way it is coming in other tumors, colorectal also, it is going to make a big space for itself. And as far as Nivo-Ipi is concerned, cost is still high. Even though the Ipi is 4 doses, there is no support of Nivo with the Ipi when combined in colorectal. So that prohibits its usage upfront in MSI high colorectal cancer patients.
Yeah, Dr. Darshana, before I go to Viraj, any comments, ma'am?
Sir, no experience with using Ipi, but preferable is pembrolizumab just because of the ease of administering and the support program that we get.
No, ease of administering or side effects. Ease is the same, I think. I think it's a 3-weekly program, so it isn't difficult to.
But I don't think the support program for pembrolizumab in colorectal is there.
Yeah, pembro doesn't support in colorectal.
The DCE is not approved. So it is
Ghanshyam,
only
no, yeah, at the moment there is no approval for in
absolutely,
India.
absolutely.
So Viraj, what do you think before I make my final comment?
No, I agree, sir. For the first line use of IO in MSI high, the way I see it is I would always check TMB, because we have convincing evidence that if you don't have high TMB, this patient is not going to do well on IO. Also, if you have a RAS mutant, giving single agent IO is not the way. Either you add an EP, or perhaps what I'm thinking is give chemo plus IO like we do in lung cancer. And I have used Nivo EP in MSI high. That patient is doing, she was brought bedridden to me after 1.5 years of chemo, no response to any treatment, just stable disease, stable disease, stable disease. And we said, let's check MSI, and MSI was high, TMB was 40. We did Nivo EP, she's in CR 1 year out, almost quote unquote cured. And another patient I remember, when a patient was MSI high, was KRAS mutant, and back then I didn't know about this KRAS mutation thing, because 177 was not out then. And we all jumped out of the chair and said, wow, you're going to get cured, I'm going to give you a magical treatment. And on my face, 2 months, patient hyper progressed with brain metastasis and extensive bone metastasis. The patient only had liver and lung, and by 2 doses of patient had bone and brain. And I knew it at that time that this is hyperprogression.
So yeah, you made a right. Can I have the next slide? You made this point on TMB, but I don't think it is necessary to use only in TMB high. If the patient is MSI high, that is sufficient evidence to go for immune checkpoint inhibitor. So just to I was asking this question for cytoreduction upfront. If somebody has, say, for example, liver-limited disease and the MSI is high, so would you use chemotherapy or would you use immunotherapy? That was the question I posed in one of the panels to Eric Van Cutsum, and he categorically said that he will not use Pembro. He will go for Nivo Ipi just because the response rates are 69%, as I showed you in the previous slide. So I mean, so MSI high is certainly a great thing to get in colon cancer in the metastatic setting, as you've been narrating your experiences, Sandeep and Viraj and others, where patients have really done very, very well. So I think this is another take-home message or a learning point regarding KRAS mutation and the interaction between the immune checkpoint inhibitors. So I think BRAF we don't have. Can we move on to the next part? Yeah, so I think we don't have the drug at the moment, but has somebody used the existing BRAF inhibitor, which we have from Novartis in our country? Any experience with Regorafenib and Trametinib, combination in
I've used it in lung cancer.
That is approved. It is approved there, right?
Yeah, I have used it in upfront.
Yeah. Ghanshyam, any?
So I've used in melanoma, so not this.
Yeah.
So we have a patient for whom we gave Panitumumab plus Dabrafenib. The patient did well for around 8 months and then he progressed.
8 months. That's a reasonably a good
He
time.
even had brain mets. There was intracranial response also.
Oh, great. Yeah. So I think maybe one can counsel the patient. And Viraj, any?
I also had one patient, Dabrafenib, Trametinib, and we ordered on compassionate ground. That time it was available for BRAF MCRC, along with Panitumumab, but progressed just in 2 months at the first scan.
Yeah. So, but I think I don't know when we'll have. Can we have the next slide? So we are just focusing on these newer molecules. Next. Yeah, so HER2 amplification. So the thought, I think Dr. Bowman did mention that if you find HER2 positivity, then we should not be using the EGFR drug in the metastatic setting. So is there a consensus there, or is there, people don't agree to this? Dr. Bowman?
I don't think so. Would be a consensus for that.
Hmm.
But you are more used to, your thought process will go in that, yes, it is not working. You would like to evaluate the disease a little bit earlier than you would do for such a patient. I don't think so that because HER2 is positive, HER2 amplification, then you would do.
So Sandeep, if you have HER2 positive,
and I would be thinking of other drugs, in fact. What we have.
The first line treatment would be, BEV with the with chemo.
Yes.
Dr. Sandeep, or you
Yes,
would
sir.
like to use an EGFR
Sir,
in the RAS
again-
wild type, and they are mutually exclusive, as is mentioned here, RAS and BRAF wild type.
So in the presence of HER2 overexpression, I will use anti-VEGF rather than going for anti-EGFR.
So I think that's perhaps an easy way out. Ghanshyam?
Yeah, same thing, anti-VEGF, sir.
Yeah, but everybody doesn't seem to be convinced on, in RAS wild type, especially on the left side, to avoid using the EGFR drug. Viraj, are you okay?
Yeah, yes, sir, absolutely. Since the paper from MD Anderson came 2 years ago, hazard ratio of 10.0 is far more convincing. It's even more worse than KRAS, using EGFR for KRAS mutation.
Okay, so I think for HER2, you have the combination of trastuzumab, pertuzumab, I think, which is going to be acceptable to all. Next slide. Yeah. So I think
Bowman sir has used one Trastu plus Per2, right? Sir?
Yes.
Can you share that experience?
Yeah. I will tell you. There was a patient who had come in intestinal obstruction after all lines of treatment. And he was a young guy. And from abroad also, I think so. I don't know, somehow HER2 was missed. And when we did HER2 and HER2 was positive and had started him on trastuzumab, pertuzumab, he started eating and obstruction went away. And he lived for quite a good amount of, till he got again a COX in between. And then slowly the COX progressed, developed. So he had a very good quality life for 8 to 9 months on trastuzumab, pertuzumab.
So you added chemotherapy or then you only?
No, I just given because the patient was in obstruction and he was in a very poor performance at
No, subsequent to the response, so you added or you continued the same?
No. I just continued trastuzumab because he just started eating or started just feeling better. Then he developed some lung lesion and we biopsy that it turned out to be COX and he was on AKT and then slowly he progressed quite well. So I did not, in fact, give any chemo. I put him on trastuzumab, pertuzumab only.
So Viraj, any comments on the IHC versus NGS, in the HER2 detection for CRC?
So what we are talking is HER2 amplification. So that is IHC. On NGS, we see CNVs, copy number variation. If so in the Hierarchical study and in the My Pathway study, both showed if you have copy number more than 6, you'll do well with anti-HER2. But for HER2 mutation, we don't use these drugs. In fact, there is one hierarchical study which is going with TDM1, and I think so tucatinib also. But for HER2 mutation, we don't use.
Right. So I think
trastuzumab deruxtecan also is a very good drug.
Yeah, I think there are slides to that effect. So I think the pertuzumab and trastuzumab gives you about 30% response rate. I think the best response rates you get in the Mountaineer study, where tucatinib is combined with trastuzumab, and almost 50% patients would respond, but the drug is not available. So next slide is on to, so I think this is by the IHC score. You can see HER2 3+ are the ones who respond the best. But if you go to the deruxtecan, the trastuzumab deruxtecan next. Yeah, so I think next slide. So that shows you, the response rates even in HER2 low, gastric cancer, and so this is an important drug, but we don't have hands on it. So that is the issue. So not only in breast cancer, but other cancers, even in HER2 low 1 or 2+, one can derive benefit from these bispecific antibodies. Next slide. I think we can. We are almost close to time. Next. So I think this is high TMB, which Dr. Viraj was referring to. So I think an important question besides this slide is the retesting of the liquid on patients who are on follow-up, liquid biopsy for looking at the evolution of the genomics, etc., or the tissue. So, what are the thoughts? Are we heading towards that, or we are still lagging behind in a big way? We read a lot in the literature. I think Dr. Shaina showed so many slides in the, and you do that in breast cancer and so many others, lung cancer, etc. So where are we in terms of, screening our patients for repeating the gene studies? Ghanshyam, is it there practical, or it's still too early?
Because the changes, the common markers we are doing, so it is not so dynamic as you see in breast and lung cancers. And probably the liquid biopsy, it is becoming, the ctDNA is becoming slowly and slowly getting established. So that's my take, sir.
Yeah. So Dr. Bowman, is it high time? Is it prime time, or it's only meant for select rich patients, or what?
Yeah, I think so. Right now, where we are, I think so it is not the prime time. Maybe few years later we would be, when things are very standardized in liquid biopsies and things are. So right now where we are, it is difficult for us to just do a liquid biopsy and on the basis of liquid biopsy try to change our whole treatment plan. Some of your mindset is not for that right now.
Yeah. So Dr. Sandeep, do you at least do a ddPCR before you re-challenge for KRAS, in a patient who has been exposed to cetuximab before? Because that is a readily available test.
No, sir. Practically no.
So you are telling me that you will, say somebody has been given FOLFOX plus cetuximab, and then in the second line, maybe FOLFIRI plus BEV, and then you have to re-challenge, you will maybe, go ahead and do the cetuximab.
No, by this time, I would have already used NGS, which is in addition to the baseline RAS studies. So NGS will give me an answer about the RAS status. So I will not go for standalone test. By this time, I would have already done the NGS.
At what time will you do the NGS? At what stage?
As soon as I start.
Yeah, that's when you start. Then that is when you're giving FOLFOX plus cetuximab in the first line. So that was 2 years back.
First line I gave on the basis of 5 markers. Okay. As soon as I start with the second line, I sent for the NGS.
NGS in the tissue, you do another biopsy, or in the blood?
No, NGS on the tissue. If the old tissue is available on that, otherwise on the new tissue.
Yeah, so Dr. Darshana, are you doing liquid biopsies to, to look at least the KRAS status after the patient has been exposed to, or you want to re-challenge with EGFR? Dr. Darshana.
So I would re-challenge. I have never only tested.
Yeah, so then not testing. Dr. Chandrakant? I think he's possibly not there. So Viraj?
Yeah. So first of all, EGFR first line, if we have to say, I must have not much patients, like double-digit number as far as I remember. So going on third line, I have started using KRAS liquid biopsy if I have to re-challenge.
That is ddPCR, right?
And that's a ddPCR, yes. Okay. Because we know now that if they are mutant, they are not going to respond, period.
Yeah, so I think at least a ddPCR before re-challenge can be performed, which is so readily available for KRAS, if not, a liquid biopsy. Although I showed you in the first slide and maybe the subsequent slide. The next slide, please. I think we are, yeah. So this is another combination which has been reported to be used in patients with colorectal cancer with some success. And similarly, I think TAS-102 with BEV, I find some, good results, although TAS-102 is not available. And I believe there are proponents of lenvatinib and pembro also in certain situations for colorectal, where, as a broad for solid cancers, the colon cancers, they found some benefit, if you're running out of chemo agents. So next, I think we can, Yeah, so this is the KRAS drug. So which has been approved for lung, and I think they haven't approved, but then, this can be considered if somebody has this G12C mutation. Next slide. So I think this is what I was saying earlier on, that this is the data for FOLFOXFIRI with BEV versus the two agents where there is some data on the survival advantage in triplet versus doublet. The last slide, maybe the next slide, towards the maintenance. So, Dr. Bowman, you use maintenance?
Yes, I've often used maintenance.
So do you use with chemo or without chemo for BEV?
For BEV, I would prefer with chemo for more. That is what my practice has been, with one chemo arm for Capecitabine.
Maybe Capecitabine or 5-FU. Dr. Sandeep?
So not routinely. I would remember only 2 or 3 old cases on maintenance. Otherwise, not routinely using maintenance.
Ghanshyam?
Yes, sir. Bevacizumab with Capecitabine. So unlike ovary, where you can use bevacizumab alone, but in colorectal, you have to use at least a chemo arm. So either a 5-FU or a Capecitabine.
No? Doctor, are you in favor of using maintenance? Dr. Darshana?
So yes, sir. Maintenance, definitely. Bevacizumab with Capecitabine usually.
Viraj, what is your practice?
Yes, sir. Almost all patients.
All patients, yeah. So in the next slide, I think that was in ASCO 2021, where Capecitabine did show the PFS, but overall survival, the hazard ratio was not that robust, 0.87 versus PFS 0.40. So I think we do prefer maintenance for most of our patients in colorectal cancers, whether it is BEV alone or BEV with Capecitabine. I think that is left to the individual. Next slide. So I think that is the last slide to sum it up here. So I think we need to do these gene testings to characterize the molecular makeup of the tumor and to decide whether to use the EGFR or to use BEV or even for immune checkpoint inhibitors. So I think this is becoming so very important, definitely at baseline and again at the time of growth. Well, this is what was mentioned in the first slide, and I again reiterate that fact. I think the issue is getting the tissue again many a times, and of course the cost factors and the lack of validation of the liquid biopsy in the subsequent, so that is an issue. I think our labs should be, should gear up to the utility of liquid biopsy, because once they convince us, come to us and show us the data, that will make sense for us, to use more of the liquid biopsies. Then I think identification of novel targets. So I think that is where we are heading to in the metastatic CRC. And although I do see there is a lot of reservation for FOLFOXFIRI in the palliative setting, but then I think a lot of physicians are switching to the triplet in especially in the advanced countries, and especially where you have more options for the molecular testing, because then you can use the targeted drugs in the second and the subsequent lines. So I think with this, if there is, are there any questions to anybody or any thoughts, any comments from Bowman or anybody, please?
So I wanted to ask.
I think so. We have some.
Yeah, Dr. Darshana wants to say something.
So I just wanted to ask, like, if there is a patient whom we have started the treatment, and it's an obstructive disease with also a metastasis in the liver. Now, after surgery, after 2 cycles maybe, if we operate for the local site because of the obstruction, do we complete the entire chemo and then do the liver, or because of the fear of blue liver syndrome or something, do limited cycles, reset the liver, and then complete? What is the way forward generally?
Dr. Sandeep, the patient with obstruction gets operated, gets a couple of cycles of chemo, has liver limited disease.
So,
Yeah, Sandeep.
so I did not get the question, sir.
Viraj, you got it?
So, no, I agree. After 2 months take out the liver. Then the liver would be damaged. And then finish the therapy as an actual.
So you would like to remove the liver lesion in between. There are two reasons. One is the damage to the liver, and the second is that the liver lesion can disappear, which can make it difficult for the surgeon to operate. So you would like to, operate in an operable patient at the end of 2 or 3 cycles of chemotherapy.
Yes.
Dr. Darshana, you get it? You got the answer?
Yes, sir. Yes, sir. Thank you so much. Thank you, sir.
So I think with this, I'm extremely grateful and thankful to all the panelists for this interactive discussion and the session on metastatic CRC. And certainly thanks to Viraj for this opportunity and invitation. Thank you very much. Thank you.